Tá na mesa do Wallace.
Posso pegar ali?
Pode. Vai precisar testar aqui?
Fala aí.
Som. 1, 2, som.
Tá chegando, peraí.
Som. 1, 2, som. Teste. 1, 2, som. Acho que já tá até rolando.
Ai, não me mata. Quando você fez aquela cara, quase que eu desmaiei.
Não, é porque eu não sou eu quem faço. Na verdade eu até faço, mas ele que tem o link de acesso lá, mas já tá.
Foi na medicina tropical. Mas é porque eles já tinham preparado tudo para usar o notebook deles lá. E aí eu vou fazer o
É que aí eu me deixei um pouco mais tarde, era só 9, né? Mas não estava tranquilo.
Mas é porque é isso, né? Se você não deitar sua
Esposa assim. É ligado de 330, não é possível.
Se você não acha que faz acontecer, ele vai fazer acontecer esse negócio, né? Porque não é simples esse Skype.
Mas que eu ia pedir pra ela, quem for apresentar, tá aqui.
Isso é a professora, né? E aí vai aparecer o slide também?
Vai, tá igualzinho da outra
igual
vez, né?
outro.
Igualzinho do X.
Na semana passada, como a gente teve aquele problema e atrasou, aí ficou um monte de gente ligando lá no laboratório. Eu tô no link, mas não tá aparecendo nada. Eu falei pra menina que tava atendendo 1 milhão de telefones. Fala pra as pessoas esperarem, porque né?
Fala que no Chrome não tá rodando, viu? No Chrome, o plugin do IPTV da USP não roda, tá?
Bom dia.
Professora, tudo bem?
Tudo bom? Olá.
Então não roda, tá? Então pede para o pessoal mudar. Eu também eu descobri essa semana.
Ela pode usar o computador dela? Eu trouxe o cabo do HDMI.
Pode, só plugar.
Tem internet, né?
Ela só vai estar sem internet, não tem problema? Ela só vai estar sem internet, não tem problema? Ela só vai estar sem internet, não tem problema? Ela só vai estar sem internet, não tem problema? Ela só vai estar sem... Vai ficar ficar em looping por causa do áudio aqui. Mas já tá transmitindo, tá?
Você fechou?
Dá um tchau pra...
Fica prontinho. Ó, a câmera
Cadê
tá
a
em cima.
câmera?
Ali, ó. Do lado do projetor ali. Bem de frente. Mas já tá prontinho.
Tá ótimo.
Então só dá um aviso, tá? Quem te ligar ou para as pessoas, não usar o Chrome. Tá?
Ah, é?
É, o Chrome ele não funciona do IPTV. Aí é uma coisa do IPTV.
Eu vou mandar uma mensagem.
Nos próximos, vou tentar ver se a gente consegue não usar mais IPTV. Tá? Vou começar a usar o YouTube para fazer a transmissão. Tá pronto.
Tá.
Pode
Deixa
ser?
eu ver uma coisa.
A gente criar o canal da Fofito.
Ah, que
Começar a
legal.
transmitir ao vivo por lá. Transmitir ao vivo por lá. Tá?
Ah, é mais fácil porque todo mundo sabe.
É, e tá mais flexível do YouTube.
Ah, que legal.
Não, it's not. It's HDMI.
Tá ótimo.
Vamos começar
Vai ser ótimo.
na próxima.
Are
a gente já
you
planeja
using
direto.
VGA?
Pra gente
Okay.
divulgar o IPTV.
A gente divulgou o documento.
O canal da Fofito.
Ah, que legal. Vai ser
E o
legal.
bom é que o vídeo já fica lá gravado também. Quem quiser assistir.
Ah, é
depois já tá lá.
verdade. Já fica público, né?
Yours?
Ai, que
Aí o vídeo que
maravilhoso.
não for
Bem
público,
melhor.
vocês restringem. Aí deixa restrito.
O que é? Desculpa, não ouvi.
Como o Chrome, eles estão desativando o Flash, né?
Entendi.
O Flash está morrendo.
Por isso que eu não
Então,
estava vendo aquele dia. Mas depois eu vi no Firefox.
Isso. Aí o Chrome, ele está desabilitando. Então, para evitar de dar esse problema, a gente começa a transmitir pelo canal do YouTube.
Ah, tá bom.
Tá? A gente cria o canal Fofito do YouTube.
Mas então eu acho que talvez você tenha a lista dos participantes no e-mail?
Tem...
Mas tá
Mas é
tudo
pro
digitado já no e-mail ou não?
Não, são e-mails diferentes.
Como esse foi
Tem que
divulgado,
avisar, né, para as pessoas que elas
Como-
vão acessar por aqui.
como esse já foi divulgado, a gente deixa assim esse curso. No próximo, a gente já faz isso.
Tá.
Depois, dia 11 é o próximo.
É,
Então, dia 12, a gente já começa a planejar isso. A gente já cria o
Tá
canal
bom.
da Fofito,
tá bom.
deixa prontinho. E é bom porque os vídeos gravados já ficam ali.
Ah, tá bom.
Acabou,
é melhor,
deu um
é
stop,
verdade.
já tá lá.
Tá bom.
Então, quem quiser, aí se o vídeo for restrito, vocês vão lá
Tá.
e restringe. Se não, deixa público.
Eu trouxe
Aí,
o HD pra
vocês
gente
compram.
copiar.
Será que ela vai usar áudio?
Are you using
Why?
audio? Are you
Why is it different than what I have on my computer?
Por que tá diferente a imagem lá e aqui?
É
Ela tá
só uma
perguntando.
tela de proteção do...
Yeah,
do
É a
it's
extensão,
their screen.
No, it's my image.
Is it?
Yeah,
Eu vou
it's
olhar
in
assim,
Montreal.
dou uma olhada.
É, mas ela tá dizendo que aquela tela é a tela do computador dela, é isso mesmo?
É o
But
experimento
it's
dela.
my...
Por que fica diferente?
É a continuação da imagem.
It's the continuation of the
Extension.
image, the
Ah,
extension
okay,
of the
okay.
image.
So, okay, that was the winter image.
Então eu trouxe o HD também para
Legal.
depois fazer a cópia. É o Fábio, é isso?
Acabar o
Okay.
streaming lá, você dá o stop, pega o arquivinho e dá pra começar. Tá?
Aí eu posso te deixar o HD?
Ah, se quiser já deixar com ele, melhor.
É.
Ele já deixa lá.
Tá bom,
Assim que acabar, ele já
tá
deixa
bom.
jogando
Beleza.
lá. Aí nos próximos, é bom que a gente faça isso. Porque aí já fica o vídeo lá, não precisa ficar transportando. Né?
É,
Já tá lá, pelo menos. Aí se for uma coisa igual, se você precisa uma restrição, só quem tiver o acesso.
Tá bom.
Será
Só
que
deixa
tem
público.
áudio na apresentação dela?
Are you using audio? Are you using
Tomorrow, tomorrow. Not,
Só amanhã, hoje não.
do you want to see it now, the
Você
tomorrow?
acha melhor deixar ligado? Né?
Quer que testa hoje?
Não, era só pra. Porque se for, a gente deixa o áudio ligado.
Yeah, because if you're
Deixa
going to
ligado, é
use,
melhor.
then he will plug.
But not today.
Not today.
Não.
Ela não vai usar hoje.
Então deixa. Deixa assim.
A gente põe amanhã.
Tá, e
Não
o
tem nenhum
próximo?
vídeo que tenha áudio, né? Nenhum vídeo também que tenha
Não.
áudio.
Does any video has audio for today? Or?
No, just tomorrow.
Então, tá, o HD tá com você.
Então, depois, só ela vai apresentar, não vai
Só
usar
ela.
o outro notebook então.
Não, só o dela.
Tá,
Sempre, só o dela. Amanhã também.
tá.
Amanhã aqui também.
Amanhã aqui também.
Transmissão também?
É,
Já tá pronto. Pelo menos é só dar start
amanhã
depois,
também.
né?
É, e não dá pra gente ver onde é que você tá usando. Você tá abrindo aí o seu pra gente ver? E a câmera tá aqui com ela? Dá pra ver ela e a tela? Como é que dá
Sim.
pra ver a câmera?
Tá igualzinho da outra vez.
Ah,
A gente
tá.
deixou os dois, né? A
Tá.
tela e ela.
Isso.
Tá?
Tá
Vou te
bom.
mostrar aqui agora.
Tá bom. Naquele dia eu tentei no Safari, tentei no Firefox e só funcionou neles, mas no
funciona
Chrome
nele,
não
é.
funciona.
O Chrome ele está desabilitando todos os plugins que possam ser ofensivos, né? Então Java, aplicativo de banco não está rodando. É só tentar o presentation de novo.
Yeah, he just has to refresh the presentation
Ô, Fábio, depois só ativa a apresentação lá de novo.
You see, the camera is there.
Da vídeo que tá fora, tá?
Oh, yeah, yeah.
You see that? It's there.
Okay, okay, okay.
Is everybody listening to it? Tá todo mundo ouvindo a gente? Come on.
Okay. So we have to be careful what we say.
Yes. Okay, great.
Funcionando, que bonitinho.
Water for you?
Tem um atrasinho de uns minutinhos, mas
Tá
é
bom.
normal por causa da
Beleza.
transmissão, né?
Perfeito.
Tá bom?
Tudo ótimo. E aí ele fica onde? Onde que fica o Fábio? Ali sim
Ele
mesmo?
fica ali, ó. É.
Tem mais alguém ali? Ou é o Fábio ali?
Não é o Fábio,
Oi, Fábio.
já chegou.
Por onde você sobe aí?
É na escadinha ali, ó. Ali atrás. Ou aqui atrás.
Ah,
Aí você dá a volta aqui e vai lá. Mas ali é mais fácil, né?
Tá bom.
Ali por fora.
ok.
É coisa só gritar. Fábio!
Tá bom. Ah, socorro. Tá bom, beleza. Você não vai ficar aqui, né?
Eu vou estar lá na sala.
Tá bom.
No transporte tudo bem.
Tá bom.
E tem os meninos aqui, a gente
Beleza.
tá tranquilo.
Tá bom.
A senhora tem meu celular, não tem?
Eu não sei.
Anota, qualquer coisa a senhora me manda mensagem.
Tá.
A senhora não.
So we even have time.
Tem uma amiga minha que trabalhou com você.
Ah, é?
A Carla.
A Carla Pereira.
Carla.
Ah, eu sei. É uma magrinha, bem magrinha da área de neuro.
É.
Fala,
8863
988
630104. Meu telefone passou pra todo mundo.
Eu só parei de falar.
Você deu o presentation lá, Fábio? É que eu tô ouvindo, já ia falar com você.
Beleza.
Deixa eu fazer assim. Vou dar uma olhada lá em cima. É, né? Não, eu subo lá, eu olho lá.
Obrigada, Ju. Muito obrigada.
Because then it's easier because it's different trials that I'm talking about. Hello. Yeah, and even if we were late, we are early. You were late? I was lost.
You got lost.
I think there was a tall, nice gentleman in front of me, so I just followed him. And I think I should have gone like So I went. I think I was behind the hospital.
Yes, yes, there is the psychiatric.
Yeah, exactly. That's where I was.
She said, I am at the
You got
street
back
of
to
the
the
hospital.
bolsas.
And then I said, okay. So I'm looking at you, but there's no shelter. And then she gave her telephone to a guy from the psychiatrist. And then I told him, send her to the metro. And he sent her.
He was laughing. It was the second time I was trying to ask him, so I think it was better that you talked to him.
Okay. Yes, I told him. She was also.
Oh, yeah.
Marina, vem cá. O que você tá fazendo?
don't know.
Even
It's
if you
very
say to
difficult.
her, you will come back. You will.
Oh, that's what I'm saying. I said, you're not in a hurry. You're not starting school in January. You're starting school only in September. Why don't you? So for her to come back, it's like, you know, that's, and she says, I don't want to face the people because they're going to tell me, you told me you were not able. I said,
Nobody can. You can tell her. Nobody will know that you are here. You only do the surgery. You stay home and you go back.
but she will see the grandparents and she doesn't even want to see them because,
But you can set her an arrangement not to tell anybody that
yeah,
she's
exactly.
coming. It's silly, but
I tried. And it's very difficult.
but did you tell her that maybe I don't have money to pay? You have to come back.
But no, I the husband, she was saying, I said, you won't do that. That's the yes, and if you won't pay, yeah. So it's really, I'm worried for her health. I'm just worried for what is her end? What, you know, where will she, because now it's that if there's problem in Asia, will she, what is her end? You know, that's what scares me.
The limit to
I
pay
don't
back.
think she has a limit. And the problem is that her health is gonna, I'm afraid of her, for her, because I think that she doesn't have a limit. She doesn't think. And she, money, health, but one time you have to pay for it. So that's what really scares me. Where's the end of that? What would be the no return and she would come back? I don't even know if there is. Because yesterday she said, you know, Mommy, there's a place in Asia, I don't know which country, that is very safe to go for health care. But even, you know, the insurance that we have, I don't think they will pay for this surgery because she already had the infection before she died, you know. So for me, they will not pay. Let's say if they pay, or if they receive the information about that and decide to pay, if she continues, they will never pay, you know, because they will say, well, she had a surgery over there. She should have come back, you know. So I think that she's playing with fire, and I'm trying to tell her, but she's,
Isn't there any way to talk to your father?
yeah, I'm fine, but it doesn't, he's, yes, to the front? Or?
Yes, I will. Yes, because otherwise will be empty spots. Bom dia. Eu sou Isabel Sacco, professora aqui do Departamento de Fisioterapia, Fonoaudiologia e Terapia Ocupacional da Faculdade de Medicina. Eu estou atualmente também como coordenadora do programa de pós-graduação de Ciência da Reabilitação, um dos 23 programas aqui da Faculdade de Medicina. Em nome desse programa e do Laboratório de Biomecânica que eu coordeno dentro desse departamento, eu tenho o prazer de trazer a professora Chantal Dumoulin para compartilhar com a gente alguns conhecimentos. Ela veio com financiamento de professor visitante da FAPESP, ela ficará conosco uns 20 dias para estreitar a parceria que começou há um ano atrás com uma aluna de doutorado do nosso laboratório, minha aluna Alicia Cassiari, que ficou com ela um ano lá no Canadá. E ela veio aqui, então, dividir um pouco mais do conhecimento dela com todos vocês. Ela é uma referência na área, ela dispensa qualquer apresentação para vocês, mas, de qualquer forma, vamos apresentá-la. Então, a professora Chantal é professora titular da Escola de Reabilitação da Faculdade de Medicina da Universidade de Montreal. Ela também é diretora do Programa de Pós-Graduação em Reabilitação do Assoalho Pélvico e diretora do Laboratório de Investigação de Incontinência e Envelhecimento no Instituto de Geriatria de Montreal, vinculado à Universidade de Montreal. Ela está participando junto conosco de vários eventos. O primeiro deles foi a semana passada, foi uma palestra, acho que alguns de vocês estiveram presentes. Hoje, então, é um curso de pós-graduação vinculado a uma disciplina de pesquisa clínica dentro desse programa de ciência da reabilitação. É um curso para mestrado e doutorado. É uma disciplina que vai ter duração de 3 horas. Hoje é 1h30 de aula. E amanhã, na mesma hora, mesmo local, mais 1h30 de aula, compondo esse curso completo de pós-graduação nessa temática que vocês estão vendo aí na aula. Esse curso de pós-graduação é o segundo evento. O terceiro evento é só para os alunos de graduação da Universidade de São Paulo e da PUC, os alunos da professora Juliana Burti, que vão estar dividindo conosco esse prazer aí de ter aula com ela para os alunos de graduação. E na sexta-feira à tarde, todos também estão convidados, é uma aula sobre a Cochrane Review, que vai ser na sexta-feira, às 2h da tarde, mas lá no Departamento de Fisioterapia, Fono e TO, na sala de webconferência. Todas as aulas estão sendo transmitidas pela IPTV, exceto a aula de graduação. Então, esse curso inteiro vai ser transmitido e a aula da Cochrane na sexta-feira. Então, eu queria agradecer inicialmente todos vocês presentes aqui no teatro e os virtualmente presentes no IPTV, que é a TV USP. Então, a TV USP está transmitindo toda essa aula, então sejam bem-vindos também virtualmente. Esses eventos só estão acontecendo por conta de vocês, então obrigado por virem aqui, por despender o tempo de vocês. And again, thank you very much, Chantal, for coming, for having a little of your time to spend with us. It's a real pleasure. It's an honor to have her here. You know that she is a reference in the area. Everybody wants to talk to her. And so, thank you very much. Se vocês tiverem dúvidas durante a aula, podem levantar a mão, que ela vai responder. E para aqueles que estão nos assistindo na TV USP, vocês podem... Oh, it's not possible. Okay, let me just... Vocês podem... as pessoas de fora podem enviar um e-mail para o meu e-mail, está digitado ali na tela, embaixo do nome dela. Então, quem estiver assistindo pela TV USP, por favor, mande e-mail para mim, que eu passo para ela durante o curso ou ao final dele. Quem tem meu contato de celular e WhatsApp, que eu sei que tem pelo menos 2 importantes grupos assistindo no Brasil nessa área de saúde uriginecológica, estão assistindo essa aula, podem mandar para o meu celular ou para o meu WhatsApp também. Ok. Espero que todos tenham um bom curso. Ela gostaria de pedir a gentileza, se as pessoas que estão mais no fundo, se não podiam se aproximar um pouquinho, só para a gente ter uma sensação de uma sala um pouquinho mais cheia. Então, acho que vocês que estão ali, vocês são a última fileira e os espalhadinhos, se vocês pudessem vir um pouquinho mais para frente, só um pouquinho mais. Eu sei que é ruim ficar muito aqui na frente, porque é chato de ver, né? Mas se puder só se aproximar um tico, ela vai ficar contente. É isso. Então, bom curso para todos. Thank you again. It's your time now.
So thank you very much for coming today. It's a pleasure for me to be here with you. I'm sorry for my Portuguese, but really if I was trying to talk to you in Portuguese, you wouldn't understand much. I could do French, but I don't know if many of you do French, so I think we should do English. So I would like to thank my hosts for inviting me here. I've been very lucky. Some of you have seen on the Facebook a lot of the activities that we've been doing, but we also have been having a lot of very nice scientific exchanges already, and we will do in the next week, and I'm really pleased to be here. Thank you for everything. So this morning, I will be talking to you about physiotherapy treatment for urinary incontinence in older women. And this is the Montreal experience. I will talk to you a little bit about all the studies that we have been doing over the years. There's a lot of studies, there's a lot of papers, so to make it easier, I thought I would make a little story out of it. So we're going to be starting today, but tomorrow's the end of the story. So at the end today, you will not have the end of the story, the fun part. So please come back tomorrow to have the full story. So this is the outline of my presentation. First, I will talk to you a little bit about us, the lab that I have in Montreal. Then I will be talking to you about the Canadian Research Chair that I have in urogynecological health and aging, with all the sub-goals of the chair. And I will talk to you a little bit about the ongoing and the future research and what we want to achieve with our research. So first, let's look about us. So you know Canada, you know, maybe not know where Montreal is in Canada. It's on the eastern part, as you can see, and it's lower part of Canada, so not that cold. The population in the city of Montreal is 4 million, so a little bit less than the number of people that you have here in Sao Paulo. And 47% of the population was born in Canada, but we have a lot of people coming from other nationalities. So it's a great place because there's a lot of different cuisine, there's a lot of different culture in Montreal. I have to talk to you about the weather because the weather is a little bit different than here. So we really have 4 seasons. I'm sorry for those who came on my first talk. I did a little bit about that in my first talk, but I will go faster. So we have the 4 seasons. In summer, like right now, we have our summer, and it could be plus 30. However, in our winter, it can go as cold as minus 30. So yes, there is a wide range of temperature. These are examples of activities that we do during the summer. We can see that Isabel came to visit us at one point, and we had a picnic on the mountain. We have a mountain in the middle of the city of Montreal. So we often have picnics. We do walks, treks, again with Isabel and Licia. We have a very nice church just in front of the lab that we can bring our visitors to. And we always have our annual pool party in the summer. In the winter, we play outside again. There's Licia, so you can see that the Brazilian can do winter too. So we go skating, we go, I don't know if you know about snowshoeing. These snowshoes, so you can walk in the snow. We also go to museums and do different activities outside and inside. This is not me, this is the students who wanted me to show you the mascots of the lab. So we have two mascots. We have Javier, the sexy cat, and we have Jamie, the baby moose. So I think that's what I'm going to be saying about those mascots. That's it. Okay, now more seriously, we are part of University of Montreal. So University of Montreal is, remember I told you about the mountain. So on the mountain, you have the University of Montreal. You can see on the upper part of my slide on the left. So these are all the buildings of University of Montreal. This is the School of Rehabilitation in the bottom. We have 30 professors. We have 115 physiotherapy students per year and 120 occupational therapists per year. So this is a very large school, because if you think about having 115 per year, they stay for 4 years. So that's really a lot of students, and the same thing for occupational therapists. It's a course for 4 years. So it's really a huge school. It is the largest school in Canada after Toronto for undergrad, but it is the largest for postgraduate. We also have, and I'm really happy to say that, we have a program, a university program for pelvic floor rehabilitation. This is the only Canadian university-based program for pelvic floor rehabilitation. It lasts over 3 years. Tomorrow I will tell you a little bit more about that program, because we have been doing studies on that program to see if we are building capacity, how are we training those people, and what is the impact on the community. So tomorrow I'll talk to you more, but just to say that the program is 3 years, because the physiotherapists are already graduated and clinician. They come not during the week, but mostly during long weekends, 4 days. Every semester, they will do 2 or 3 long weekends, and this lasts for 3 years. And after that, well, we have 20 students every year that join the program. So over 3 years, it's always 60 students at the time. So we're really proud of that, because we are improving the number of physiotherapists able to treat patients in the community. So this is good. This is our research center. The goal of the research center, the mission is conducting research on health system and services, as well as biomedical, clinical, and social, cultural, and other factors that have an impact on the elderly. So it is a research center on aging. And it can start not only when you're 65 or 70 or 75. Aging starts when you're born and you start aging. So there is different research along the way of our aging path. There's 2 main teams. The team 1 is neuroscience and aging. As you know, the cognitive problems are very prevalent and have a very important impact in the elderly people. So we have a lot of researchers working on that. But we have a second team that is health promotion, care, and intervention. And that's the part that I'm in. We have 52 researchers, 270 students, postgrad students, and we have 36 postdocs. So this is our laboratory. We have a small gym for the pelvic floor. So as you can see on the top left, we have a small gym. Then we have different rooms either for evaluation. On the bottom left, you have the rooms for evaluation. We have 3 of them. Or treatment. There's one on top there. And we have access to different kinds of equipment. For those of you who know me for a while, you probably know me for my torture instrument, the pelvic floor dynamometer. So we built that. Actually, I built that with my dad when I was doing my doctorate to study pelvic floor muscle function. But we also have access in the research center to MRI. And we have 2 ultrasound machines to look at the morphology of the pelvic floor. We also have different units to train the pelvic floor, biofeedback, electrical stimulation. And finally, you probably recognize that game on top. What is that? Do you know the game? Dance Dance Revolution? So you're going to see later, and if you come back tomorrow, you're going to dance with me, because we have some of our projects in which we have dancing. So I will tell you later why. Okay, so that was us. Now I will be introducing you to the topic and trying to convince you why it's important to study urinary incontinence and pelvic floor dysfunction. Although I think that most of you are already very convinced it's an important area. So, incontinence in older women. The prevalence of incontinence in older women is, according to the literature, 40 to 55% of the women that will suffer from incontinence at that age and getting older. So this is 1 woman out of 2. This is a lot of women. Mixed incontinence, whoops, it just moves on its own. Mixed incontinence is more prevalent than stress incontinence and then urgency incontinence. In older women, you often see more mixed incontinence. 20 to 25% of those women suffer from severe symptoms, which is more than 10 episodes per week. So this is not just, a few drop a couple of times a year. This is a very important problem for at least 20 to 25% of them. Urinary incontinence is one of the 4 health priorities for older women. There was a study, the WOW study by Dr. Tannenbaum in Canada, in which she was asking the women, which are your main health tissue priority? And for women, it was osteoporosis, the risk of falling, having memory problems, and urinary incontinence. These were the main problems. So incontinence is really important for aging women, and it is very prevalent. What is the impact of urinary incontinence? Incontinence can be very expensive. I don't know in your country, but in Canada, the government doesn't pay for pads and pants. I don't know here. No, the government doesn't pay. So can you imagine elderly people having to pay for that? Often they put Kleenex, they reuse their pad. It's very difficult for them because it's very expensive. It has a very negative impact on quality of life. Older women that have incontinence will isolate themselves because they don't want to smell. They will reduce their physical activity, while we know that, I don't know why it's moving forward like that. They will reduce their activity because they know that they are afraid of having incontinence. But we know that for older people, it's very important for them to continue to be active. They will not be in contact with others. So again, for their cognition, it's not good. Incontinence increases the risk of falls and a nursing home admission. So this is not only a few drops a few times a year, but it can get to being very bad. urinary incontinence impact quality of life more severely than other chronic pathology, such as diabetes. And this was a study by Coe in 2005. This is quite interesting. So now we know that incontinence is prevalent in older women. Incontinence has big impact. Let's go back to Canada and let's see what's the impact of incontinence in Canada. Well, it costs a lot of money to Canada. Treatment and related medical problem add over $3.8 billion to the healthcare costs of Canadians. The number of women affected is set to rise significantly over the few next years as we have baby boomers, and I think you have baby boomers too, that are getting older. So from 16% of the Canadian population in 2011, which are women 65 and up, we will go to 23% in 2026. So there's going to be much more women, and with that, much more women with incontinence. So is there a solution to help those women with incontinence? Well, there are different treatment options, as you know. We know that conservative management is the first-line treatment. Those of you who came last week, I showed you the latest evidence in conservative management for incontinence. So there is pelvic floor muscle training, PFMT, which appears to be very effective, bladder training, and lifestyle change. If this doesn't work, there is also pharmacological treatment or surgical treatment. So there are different treatments to treat those patients. Clinical practice guideline, as I told you, supports the use of the first-line treatment. However, I don't know if in your country, but in Canada, it's not all the women that can do pelvic floor muscle training or any of the other conservative management. And I will tell you later, but there is a lack of money, of course, and there is a lack of professional to give the service. The Canadian Incontinence Foundation strongly recommended that the government invest in conservative treatment. And this was in 2014. Knowing that the problem's going to increase, the cost's going to increase, we need to do something at this point in Canada. So as I was telling you, the lack of financial resources, because of that, because of the number of women to be treated, we need to develop effective low-cost treatment. So treatments that may be group treatment would reduce the cost. Now, if you are a physiotherapist and you are practicing right now, you will say, well, Chantal, this is not for everyone. It's not all the patient that can do group. Some patient needs to be one-on-one. What I'm saying is not we would do group for everyone. I'm saying for those in which it's sufficient, we could do that and then keep more money for the ones that need one-on-one. Okay? So we need to study for which patient group would work and for which it wouldn't work, and then we have to develop other treatment for them. There's also, like I said before, a lack of human resources to carry out the intervention. In Canada, only 6.2% of the physiotherapists practice pelvic floor rehabilitation. I don't know the numbers in Brazil. Is it higher than that? Do you know? You don't know? So we have about 264 physiotherapists that can practice pelvic floor rehabilitation. Most of them are in the Montreal area. Very few are all over the province. Most of them are in the private sector. So if you think about older women with not much money, it's not really helpful. And in the private sector, the cost of treatment is around $120 per session. And even with that, the waiting list is 6 to 9 months in the private. In the public, it can be 2 years. So if you're an older woman with that problem, that's very long, and you increase your risk of complication. So you see now the context, and with that, as a new professor, I was encouraged by my department at the time to apply for a research chair. A research chair in Canada for associate professor, because I was an associate professor at the time, will make you take 80% of your time working in research and only teaching 20% of the time. So it will give you more time to work on a research program. So that is what is called a research chair. However, you're going to have to develop that area and give results. And also, when you have a Canadian research chair, a lot of your teaching is related to your research in order, as I said before, to increase the capacity of people being able to transfer that new knowledge into the clinic. You understand that? Yeah. Okay. So this is the different goals of my Canadian research chair. So if you look in the middle, the main goal is to improve continence care in older women through a more targeted and effective treatment plan. As I was telling you before, more targeted would be if this woman needs more one-on-one, then we will target that woman. If another one can do group treatment, we will go and do group. So more targeted and more effective. And to do that, we have 4 sub-objectives. The first one is to better understand the problem in older women. Is urinary incontinence, when you're 65, the same problem, the same causes as if you are 25, 30, and you just had your first baby? Probably not. Do we know a lot about that? Maybe not enough. So the first sub-objective is to better understand, and we do that through 3 different elements. We do that through listening to women. What do they think about their problem? And I will present to you the studies we have done about that. We will look then into the pathophysiology. Remember, I have that equipment to evaluate the pelvic floor. And we will also look at the evidence. What do we know about the pelvic floor? What are the evidence? What is missing? Where should we go from there? Okay? So this is the better understand part. And I will, like I was saying at the beginning, I will tell you little stories, some studies we did in that area. Second goal is to better treat. So to better treat, what can we do? To better treat, we have to build more cost-effective treatment. Remember, I told you that there's going to be so many women that we cannot treat them all one by one. So we have to develop more cost-effective treatment. We also have to find adherence strategies. For you who are working in pelvic floor rehabilitation, but actually I think it's for all physiotherapists, we always have problem with adherence. Our patient, when they start doing treatment, they are adherent, but then as it goes better, they stop doing their exercise and we have problem with long-term effect. Now, if we want to face that problem, we have to have long-lasting effect. So it's very important to better understand adherence strategies in order to make those cost-effective treatments last longer. So I will talk to you today and tomorrow about those studies. Then, after we build good treatment, we have to better predict. Coming back to what I said to you before, better predict who will benefit from a certain form of therapy, who will not, in order to direct that person directly to the good treatment in the first time and lose less money, less time for the clinician and for the patient. So developing a clinical prediction rule is something that we actually just got funding for. But I will talk to you about the pilot project related to that. But at the end, if you want to make sure that what you're doing in research has an impact on the community, you have to implement. And on that, I will talk to you about the studies and also about the tools that we develop to implement those results, because we already have some result in the better treat. So we now have some tools that we can implement in the community, and we also developed a micro program, the program for the physiotherapists, to increase the capacity. So as you can see, these are the 4 sub-goals, and today and tomorrow I will be talking to you about that. So first, let's start with the better understanding. In the better understanding, I will present you 5 types of studies, and I think I will start now. Is it okay? Is my speed okay for you? Am I too slow, too fast? Okay? Do you hear me well? Okay. So the first study in my story is to know more through the patient what they need. So what we did, the first study I did when I started my Canadian research chair was to do a citizen jury study. And this was published in Neurourology and Urodynamics. So the title of that study was Research Priorities for Elderly Women with Urinary Incontinence. So as you know, most studies on urinary incontinence are initiated by clinicians, researchers, or even pharmacological industries. Women with urinary incontinence are rarely involved in developing the research question or the methodology. However, recent studies have shown the need for women with incontinence to be involved in those studies, because if they're not involved, they might not adhere to those interventions at the end. So the outcome of these interventions might not be as good. So the failure to include beneficiary in research discussion could result in poorly designed research questions and poor prioritization of research. The ultimate consequence would be minimally applicable research results, hence less transferable to the targeted population. So we decided to run a citizen jury. Do you know what a citizen jury is? For a citizen jury, you need a jury, which is a group of persons that represent the problem. So here we had a group of women having incontinence. And what we do is we present the evidence to that group of experts. These women are experts in the area. So we present the evidence, and then the jury deliberates about question about these issues, these evidence. So what we wanted to do was to identify the research priority for older women with incontinence for future research on incontinence intervention most significant to them. So the study design was a qualitative study using the citizen jury approach and a nominal group technique. And as you can see on the top there, this was the presenter in the front, and all the ladies were sitting at tables, and they were participating in this citizen jury. So participant in that study, it was a one-day study. This is wonderful because you just do your acquisition on one day. You have to prepare well. It's like a wedding. But when you're there, it's only one day. You get all your information, and then you analyze. So participant, women 60 and older, they needed to be ambulatory. They needed to be able to go there. They needed to have symptoms of stress, urge, or mixed incontinence for at least 3 months during the past year. We didn't want to have those with novel incontinence. We wanted them to, or incontinence just because of an infection. We really want to have patients with urinary incontinence. They had to agree to complete the ICIQ-UI short form, which is a standardized questionnaire on incontinence that you know. And that was helping us define what type of incontinence they were having. Because in that questionnaire, you have questions about stress, mixed incontinence, and that's where we were separating that. And then they had to fill up a 3-day bladder diary to have an impression of the severity of their symptoms. So we put information in the papers in Montreal, and we also advertised through the Foundation of Incontinence of Canada that we were having that great day where there would be experts explaining the evidence, and that we wanted to know more about the concerns of the women. So as I said, we did presentation of the latest evidence-based literature on incontinence, incontinence outcome and incontinence intervention, and for that we used the ICI book, the International Consultation on Incontinence book, and also the Cochrane reviews. And I just want to tell you, these are our experts there. I was introducing, there was Mélanie Morin, some of you might know her, she's the physiotherapist expert. There was a urologist, there was urogynecologist, there were people talking about medication, another urologist. He was talking about evaluation. So we had all those experts giving the same amount of time about each of those modalities with the same background, same number of slides. This was very, very standardized in order for people not to go for an intervention because they like the presenters. So we really try to make it as standardized as possible, same amount of time, really, really rigorously standardized. Then after that, we gave them lunch because that was a very big morning. They had all those lectures. So we gave them a very nice lunch. Like I said, it's like a wedding. And then they were guided by a facilitator from the education faculty. We got a facilitator that was trained with focus group, and they were invited to discuss their views and to identify priorities into research, knowing what has been done, what would you think would be the areas of research we should look into? And we use the nominal group technique in order, and this is a methodology in qualitative research, in order to identify first the 5 most important areas, and then from that, vote for the 3 first one. And between the 5 and the 3, there can be discussion by the group in order to maybe go back, change the position of some of them. So this was done in a group, making sure that everybody was able to talk, not only that lady always talks more than the other ones. So this is the characteristics of our population. Mean age was 70 years old, and BMI around 24, 25. If you look at their medication, they're older people. Most of them were taking about 3 medication daily. Something very particular and maybe limiting into the external validity of this research. If you look at the education of those women, look at that. A lot of them were university, so very high level of education. Is it because they're the one that get involved in such studies? Or are they the one that read those ads in the paper? Although we use all the newspaper. But, you know, this is a limit of our study. Now, if we look at the symptoms of those women on the ICIQ, yeah, I can show you, we had 13 that had stress incontinence according to the ICIQ. 14 that had urge urinary incontinence, and 16 that had mixed urinary incontinence. And you can see that they had, the level of the symptoms was moderate. Number of micturition a day was higher for the urge incontinence, which is normal. Number leakage, again, a little bit bigger for the urge incontinence, and the number of pads also. So this was our population. You may think this is not a lot of participants, but for the type of study, for citizen jury, for qualitative study, this is the number of participants that is usually taken. Now, let's look at priority of intervention by incontinence type. And you can see that for the stress incontinent and also the mixed incontinent women, physiotherapy intervention was the first priority. There should be more research into physiotherapy than it was lifestyle intervention. They wanted to do more about their diet, about weight loss, about things like that. And then they wanted to know also more for the stress about bladder training, for the mix, who had more leakage, as you saw before, know more about pads and protection. Interestingly, the urge incontinent women wanted more research in surgery. And as you know, for urge urinary incontinence, the main treatment is not surgery. So they were a little bit upset by the fact that the others could have surgery for their incontinence, but that for them it was not possible. So they wanted to have different treatments, something more interventional maybe, to get rid completely of the problem, because remember, these are the women that were having the most symptoms in the group. But however, you can see that in the 3 main priorities, there was also bladder training and physiotherapy. Some of the comments, it's in French, but I will translate. I would like to know the factor, the risk factor for incontinence, so I want to be in control. I want to be involved in my incontinence. I want to get involved in my treatment. I want to do exercise because it's natural. I don't want a surgery. I don't want the side effect. So you can see that for older people, these were important. She wanted to take charge of herself. Think also about older people wanting it's very important for them to be in charge of their life and their health. They don't want to have somebody else taking care of them. And they were saying we need to do research to improve the product of incontinence. And they don't want to see it. We need to have something that is close to the body. So there's a lot of problem also about stigma in that subpopulation. So they really want it to be as normal as possible. So this is what we get from the first part. But this is the second part of that study, and I thought it was very interesting also. With the first part, we knew which areas was most important for those patients. With the second study, we just wanted to see if what we had given them during the morning, these information would have an impact on them. Would they consult the doctor more about their incontinence? Would they lose weight? Would they do something? So the title of this study is From Passive to Well-Informed Active Participant, the Impact of the Citizen Jury on Self-Management. And the goal was to evaluate the impact of this 3.5 hours interactive presentation of evidence on behavioral change in women with urinary incontinence. So this is the second objective of our citizen jury. So this is the same design, same participant. Again, we present in the morning. What's new now is what we did after. So immediately after, and when they were in groups of discussion, we asked them to complete a satisfaction questionnaire. Were they happy about what they had learned in the morning? And then a learning behavior questionnaire. What is it that you have learned, and do you intend to employ or to change or to maybe consult a doctor to have an impact on your incontinence? And then 3 months after the wedding, after the study, we send them an envelope in which we send a questionnaire again. And we ask them, you know, you had told us that you were going to change some behavior. Have you changed your behavior? And if you did, what were the behavior that you changed? And we also put bladder diary in it to have an idea of the change in incontinence. So these are the results. Immediately after the intervention, most participants were very satisfied with the presentation of the expert. Clarity, they were very satisfied, 89%. Content, 86%. And they really enjoyed the meal because 90% said that the overall activity was very good. However, most importantly, 72% of the participants indicated that they intended to change the way they manage their incontinence. 72%, and it was only a 3.5 hours information. So they said that 64% of them said that they wanted to practice more exercise. Some said that bladder training and fluid intake, they would change that, 54%. Lose weight, 90%. And as you can see, the stress and the mixed incontinent women were more likely than the urge, who were really a little bit upset about not having surgery, to change things. Okay, so that's what they said they were going to do on the same day. If we look at 3 months now, at 3 months, 83% of the participants had integrated some self-management behavior in their everyday life. 80% changed the fluid intake and did bladder training. 72% said that they were practicing regular exercise. And it's not because the expert showed them how to do it. It's because they heard about it and they went on the internet and they tried to do it. 13% went to see a physiotherapist, and on and on. But I think most importantly, if you can see the little square at the end, using the bladder diary, we found that in 44%, there was a reduction in symptoms of incontinence on the 3-day bladder diary. In 25%, the interval between micturition was increased, and in 63%, they found the education session reducing their incontinence. So I think the message is two things. The women in the citizen jury felt that they want to get involved. Older women want to get involved. They want their self-management through conservative management intervention. This was the highest priority, at least for mixed and stress-incontinent women. And they also interactive multidisciplinary urinary incontinence education within the jury did promote the desire to adopt new behaviors immediately after, but we could see that at 3 months it had really changed. So what does that mean for my Canadian research chair? Well, that means that I found partners. I found partners into the intervention. That means that I had to design trials in which the women would be very active and they would have to control their intervention. And you will see later that we built a randomized trial around something like that. Now, so we knew a little bit more about what the women wanted. Now I bring you back to my torture instrument, and I talk to you a little bit about the function of the pelvic floor. So yes, it's good to know that the women want to do exercise. We need to know which exercise to give them. And to know that, we need to know what are the dysfunctions with the pelvic floor muscle. So this is the Montreal Dynamometer, the instrument I told you I built with my dad. And that was before my chair. This was during my doctorate degree. Now, I don't want to scare you. I just want to show you, see how big it is? It's not that big, okay? It's about the size of a finger. So we have 2 units. The first unit we did was a 3-bladed dynamometer. So the lower branch will pick up, because it's instrumented. Maybe I can use that. Can you see that? Can you see here, the red? So on the lower branch of the dynamometer, there's strain gauge. And those strain gauge, they will react to the deformation of the branch. So if there is a contraction, the forces will be applied under this branch, and the instrumented branch will monitor that change in force. So that would be the pelvic floor muscle. You will see later how it's entered into the vagina, but the force would come here, and you would measure the force of the pelvic floor muscle. We did a branch on the top that is just against the pubis to stay in place. So this is not instrumented, it's to keep it in place. And actually, we had a 3rd branch, which was also instrumented, which could record the forces from the deep abdominal pressure, from the deep abdomen. So indirectly measure the pressure in the deep abdomen. This is a little bit tricky, forces and pressure. So here, the dynamometer, you have what gets inside. This is just this part that gets inside. So not so long, about the length of the of the vagina. This can open and close. So you can see the two branches can open and close. Here we have something that makes it open and close, a little manivelle. Open it and close it. And this way we can actually get information about the elasticity of the tissue. And we do that in women who have pelvic pain, who have vestibulodynia. We have had a couple of studies on that. Opening it also, we did length tension curve. So to understand better how the pelvic floor muscle react at different sizes. Now, we can angulate the dynamometer in order to get into the vagina at the right angle. And then, because we're Canadian, we also have a skate here. So we can bring the dynamometer inside and outside, sliding it through our skate to get inside the vagina. So see, this is how it gets inside the vagina. And when there is a contraction by the pelvic floor muscle, we can record a curve like that, which is the contraction. So we monitor what is happening before, the passive force. We monitor also the activity, the forces produced during the contraction. And we have different tests that we make the patient do. We can make the patient just look at the passive force, look at the elasticity, go to the maximum, come back, do cycles. So we can look at hysteresis. And then we can do maximal contraction, rapid contraction, endurance, and different things to have a better information about the pelvic floor. So the dynamometer, as I told you before, the lengthening or the shortening of the strain gauge will cause its electrical resistance to change. And then it's going to be amplified. The voltage values will be amplified from the strain gauge, and then it will go to an acquisition card where the values are digitized and converted into units of force, into Newton. And then the computer will present the pelvic floor force measurement in data, just as you saw before, in graph and in data. Okay. And we have many publications on the dynamometer. I didn't want to come back to all that. This is very old. But we did a lot of psychometric evaluation, repeatability, test-retest, validity. And this is a good instrument, actually, to measure the force of the pelvic floor. So, going back to our older ladies now, we did a study in order to look at more specifically what were the problem in the pelvic floor of those women. And we did that because we wanted to, as you know, develop better treatment for those women. So the goal of this study, again published in the journal, Neurourology, is to identify pelvic floor dysfunction in stress urinary incontinent older women compared to continent women. So in that study, that cohort study, we had 30 continent and 59 stress urinary incontinent postmenopausal women. And the method was to look at passive and active pelvic floor muscle function in these women. And we use ANCOVA for controlling age and parity into our statistical analysis. Now, if you look at the results, what we found, and this is very interesting, the only parameter that didn't seem to be significantly different between continent and incontinent was strength. And often we think, oh, you need to strength your pelvic floor when you're incontinent. Well, it appears that there's other things than strength that might be problematic in an incontinent woman. So, for instance, the passive force that was produced was different in continent women and incontinent, favoring the continent. And that was at rest. Then, like I said, we did the maximal contraction. Although it was higher here, there was a lot of variability, and because of that, it was not significantly different. Then we had a task asking the women to contract as fast as possible during a 15-second task. And we looked at the rate of force development, or the slope of those contractions, because we actually asked them to contract as fast as possible. And we saw that the continent women were much faster than the incontinent women. They were able to do more rapid contraction in that 15 seconds. So not only they were more rapid, but they appeared to be more coordinated than the incontinent women. And then we did that test, which Isabel says we are really Canadian way of evaluating endurance. That test is to ask the women to contract maximally and then to hold it for 90 seconds. Yes, I know, 90 seconds is long, but we really wanted to see how the muscle would fatigue over time. So it's more than a minute, but we look at the integral after the 10 first seconds and for 60 seconds, and you can see that the endurance in the continent group was much better than in the incontinent group. So just to do a small conclusion, we found that in older women, problem was not strength, but a lot of other things. The passive force, the tone at the beginning, the rate of force development, the rapidity of the contraction, the coordination, and the endurance. So we thought we really have to put that into our exercise program that we will give to those ladies if we want them to get better. So we did some trials in pilot studies, not randomized trials, just seeing if it was improving. So we did some trial in order to identify, which one is this one? Oh, okay, I'm not finished with the dysfunction, sorry about that. I want to show you what we have found in the dysfunction now between mixed and stress incontinent. Remember the other one, the first trial I showed you with dynamometry was with stress incontinent. But because in older patients we often see mixed incontinent, we wanted to see, and this was another student doing that, if there was different deficits or dysfunction between stress and mix. Should we treat our patient the same way if they have stress incontinence or mixed incontinence, or should we use different exercise program? So the aim was to identify specific dysfunction in stress and mixed incontinent women. So we had 20 continent, 20 stress, and 20 mixed incontinent postmenopausal women. We use MRI to look at the morphometry of the tissues in those women. What we found, and I think we should start by the stress incontinent. For the stress incontinent women, we found a higher occurrence of bladder neck funneling. So you know the funneling is the opening of the bladder neck. And you can imagine if you have an open bladder neck, when you cough and you sneeze, there's going to be leakage more easily. And there was a larger posterior uretrovesical angle. And again, that goes with the opening of the bladder neck. If you have a posterior uretrovesical angle that is larger, you have a funnel in your bladder neck. So what does that mean? Whoops. What does that mean? Is that for women with stress incontinence, we have to find intervention to try to reduce that funneling if we want them to reduce their stress incontinence. And we know something that helps that. We know the neck. You know the neck? The contraction prior the cuff. And probably this is what it's doing. It's just closing that bladder neck. So, of course, in women with stress incontinence, we need to include that exercise. We already do, but this was something to help us understanding even more. For the mixed incontinent women, the older mixed incontinent women, what we found was that the pelvic floor muscle was lower, sitting, resting lower, and also all the pelvic floor organ support were lower. What does that mean? Well, the passive tone of the pelvic floor was not as good as the stress and even as the continent women. So in those women with mixed incontinence, the interpretation of that would be that we would need to maybe use some exercise that could help increase that tone or lift that pelvic floor. Now, what is that? It's very difficult to answer just like that. But if you look at the literature on exercise that are more longer duration, submaximal, tend to increase the tone of the muscles rather than really rapid and maximal exercise. So that told us that we had to include these types of exercise in our program. But of course, this was an hypothesis, and we had to test that. You still following me? So, and that's where I was. I thought I was there before, but now I'm there. So what we did was we did pilot studies in which we tried different exercise programs. And we tried to aim at those deficit or dysfunction, and we tried to see if we were able to change it through different exercise programs. So here we had 27 postmenopausal women with stress incontinence. And what we did was a pre-post cohort study with a physiotherapy intervention and with pelvic floor muscle exercise. And what we found using dynamometry, MRI, and also EMG was there was an increase in pelvic floor support at rest and during contraction. So remember that lower tone that we found with dynamometry in the first study I showed you? There was lower passive tone. Well, we could see that there was a higher tone. Increased support at rest and during contraction and Valsalva with the MRI. We saw in the other study that for mixed incontinent women, the pelvic floor seemed to be lower. So with these treatments, we made it higher. Increased contraction speed with dynamometry. So our program was acting on contraction speed. More rapid activation according to the EMG, and force maintained during repeated cough. So with our exercise program, we didn't achieve all the problem that appeared to be happening in the incontinent women, but we achieved a lot of those. So this was a work in progress, but we saw that there was some exercise that should be used in our main trials. We also looked at the impact of pelvic floor muscle exercise and changes in the urethral sphincter. Because, you know, sometimes we think that, yes, we're acting on the pelvic floor, but we had a student that wanted to see if we were also acting on the urethral sphincter. And I think this is very important, especially if you're going to be working with women with sphincter deficiency. if you're going to be working with men, it's important to know if we're only acting on the pelvic floor or if we're acting also on the urethral sphincter. And post-physiotherapy, we found that there was an increase in the sphincter thickness, 24%, by 24%, increase in the cross-sectional area of the sphincter by 20%, and an increase in the volume. So interestingly, that was the first study to show that not only by doing those exercises we are acting on the pelvic floor, but we also appear to be acting on the sphincter of the urethra. So this was a really rapid, I know, but this was an overview of what we had done with the pelvic floor. So now we knew about the women who wanted to get involved. We knew more about the dysfunction of the pelvic floor muscle. We had an idea about the exercise program we could use to improve those dysfunction. And now we wanted to look at a larger picture because older women that have incontinence we are physiotherapists, so we wanted to look at the whole body. But older women with incontinence often have problems with lower limb also. So we wanted to look at the deficits in lower limb muscle strength, balance, and mobility in older women with mixed urinary incontinence. Because, as I said to you before, there is a higher risk of falls in women that are incontinent. So maybe in those women that are incontinent, there might be maybe not only the pelvic floor, but there might be something about the lower extremity that needs to be looked at in our intervention. So as I said, mixed urinary incontinence has been independently associated with increased risk of falls among aging community-dwelling women. Possible causes, or maybe urgency, the fact that it's really urgent, so you will go rapidly to the bathroom, and there might be something in the environment, so you will fall. It might be related to executive function problem or physical function deficit. It's possible that older women who have incontinence, because they don't do as much physical activity, because they're more isolated, maybe that's why also they have lower limb dysfunction. So in order to treat them more globally, we wanted to look at that. So we did compare continent and mixed urinary incontinent older women, and we wanted to see the differences in lower limb muscle strength, balance, and mobility. And we wanted to see the association between the severity of the incontinence and the lower extremity deficit. So that was also a cohort study. We had 20 older women with mixed urinary incontinence and 20 older women with no incontinence. They were matched in terms of BMI, parity, and also severity of incontinence. Inclusion criteria was to be 65 and over, living in the community, and being able to move safely without any aid device, able to follow simple instruction in French and English. The outcomes. We had the ICIQ-UI questionnaire, again, for the severity of the symptoms. And we evaluated the strength with the biodex measurement, knee flexion and extension with the dominant and non-dominant leg at 30-degree and 60-degree angle. That was for the muscle level. We also looked at balance with the unipodal stand test, the four-square step test, and the activity-specific balance confidence scale. So the ABC scale is a confidence scale in your ability not to fall. We did also mobility testing, 10-meter walks and 6-minute walk tests. And we did different functional tests, the 30-second sit-to-stand test, the human activity profile, and the SF-12. These are the results for the demographics. The continent, of course, they had a 0 on the ICIQ. The mix had 11 on the ICIQ. So it's a moderate score. The SF-12, there was a difference. The one with mixed incontinence, they had lower health status. The mental health status was similar in both groups. And the ABC scale, so the balance scale, was lower in the incontinent group. So the incontinent were less confident about their balance. But remember, they were matched between them for parity and for also weight, age, etc. If you look at the balance result, the unipodal stand test was significantly different, with the women without incontinence having much better results. The unipodal stand test on the non-dominant limb, again, significant difference between the two groups. And the activity-specific balance confidence scale, very different between the two groups. If you look at the mobility results, there was a problem with a difference, significant difference favoring the women without incontinence with the 10-meter walk test. And there was no other significant results between the two in terms of mobility. Finally, looking at strength, there was no significant difference in the non-dominant or the dominant flexor or extensor muscle, knee muscle, between the groups. So, conclusion. This study provides some evidence that balanced performance and confidence in balance, as well as mobility, appear to be affected in elderly women suffering from urge and mixed incontinence. Therefore, the assessment and treatment for these older women with incontinence should not be limited to the urinary symptom. Now, this is a first study. We are now looking more into, because this is really complicated, so we're looking into what's happening not only when you walk, but when you walk and you need to go to the bathroom, because that's actually very important for the incontinent women. But at least right now, we think that our intervention that we do for incontinence may not only include pelvic floor exercise, but also include some lower limb exercise in order to improve balance and to improve mobility. So you will see that we have thought about that, and also something from the clinic, actually, that probably your patient have told you in the past. Yes, I know how to do my exercise. I know how to contract my pelvic floor, but when I'm walking, I cannot contract anymore. So that's why we think that we should look more into this lower extremity area. Okay? And you will see that we have tried to include that also in our intervention. Am I still okay with time? A little bit late? Okay, so maybe I do one last study. Okay, 10 minutes. So I will talk to you now about executive function. Is it associated with mixed incontinence in older women? Okay, so now we know older women, they want to be involved, they have problem with their pelvic floor. Maybe on the contrary to younger women postnatally, they seem to have issue also in their lower limbs, maybe mobility, maybe balance. So maybe we should take care of that. But what about cognition in those older women? What about cognition? So the context is that in relatively LT community dwelling women, there has been an association between incontinence and cognition. And that is ambiguous because some studies support this relationship and other study doesn't support this relationship. If there is an association, it might be because it is not in all the type of incontinence, but also it might be different cognitive function that are involved. Maybe not the MMSE, the more general tests might be not involved, but maybe specific cognitive areas might be involved. And we thought that this was very important to study because if we want to be making cost-effective, long-lasting treatment for older women, and if they have the cognitive deficit, maybe we have to act with them in a certain way to make sure that our intervention are adapted to them. You get that? Okay. So the aim of this study was to look at the association between cognition and the presence of mixed incontinence. Mixed incontinence, remember, which is the incontinent type that is more prevalent in older women. So we had 32 continents and 83 mixed incontinent women. This was again a cohort study. And what we did with the help of neuropsychologists in our research center, we looked at a large battery of cognitive tests. So the general mental status, which was used in most of the studies and which didn't show any difference, but also other testing that are more specific to different aspects of cognition. So these are the results. You can see that there was significant difference between the continent and the incontinent group, not for all the tests, like the MMSE was not different, but if you look at the Stroop flexibility, the trail, and the dual mixed trials, those tests look at divided attention. Those tests were all different, and they were favoring the continent women over the incontinent women. What it means that the women the incontinent women took more time to complete the flexibility condition and made more error in the inhibition test. They took more time in the Trail B test, which is a test that involves switching from one information to the next. And they had very much difficulty in divided attention. So what does it mean for us physiotherapists? It means that mixed urinary incontinent women demonstrated poorer performance when they were doing executive function and when they had to do two things, divided attention. So when they had to do two things at the same time. So that would be like walking and contracting your pelvic floor in order not to have incontinence. So they really had difficulty doing dual tasks. And maybe that could be an hypothesis why they fall more. But we know that they had that problem of dual tasking. They had difficulty disengaging their attention from one task to perform the other. So they're walking, and they have difficulty, continuing doing that, putting less of their cognition to that task to contract the pelvic floor. And can you imagine if they're crossing the street at the same time, or doing something, or if there's something down on the floor and they don't want to slip on it, they want to go around it. So they have very much difficulty doing that. Also, they have difficulty coping with interference. So if there's a noise, if there's somebody talking to them and they have to rush to the bathroom, they have difficulty doing that. So what our conclusion was that physiotherapists should consider these dysfunctions when teaching and practicing pelvic floor exercise in older women. So what we did was the program that we developed had to involve something for cognition. And that is where we got the dancing from. The dancing is used by researchers because the dance revolution is a cognitive task because you have to follow arrows at the same time as you have to do a second task, which is to put your feet on different places on the arrow. And that is standing up. That is difficult for maybe women who have mobility and balance problem. And at the same time, the dance, and I will show you the studies tomorrow, but you know the dance, they make you go laterally, opening like that. That can be difficult for the pelvic floor, and opening like that also. So this is similar to walking, similar to activity of daily life, and we introduced the dancing in order to work on the pelvic floor, work on the lower limbs, and also work on the cognition. So you understand all those, why we got to that? Good. So this is the end of the story for the what we wanted to know in terms of pelvic floor, lower limb, and cognition. Now, the last part of our first sub-objective of the chair was to know more about the evidence. And I will go rapidly into this one just to show you a part of our work at the lab is also to look at evidence. We do Cochrane reviews, and we are involved in the international consultation on incontinence. And this review is pelvic floor muscle training versus active control or absence of treatment in women. And I will present that to you rapidly just to show you what at the end or the problems with the evidence, what we are missing, and you're going to see the last link to what we're doing in the lab. So pelvic floor muscle training are a common treatment for incontinence in women. Oh, sorry, I have something in my screen. It is also recommended for mix and rarely in isolation for urge. Usually it's with bladder training. There, at the time where we updated that review, there were new trials eligible for inclusion, and we needed to look at them to see if the recommendation from the review would stay or would change. So the objective was to test if pelvic floor muscle training was better than no treatment, placebo, sham, or any other form of inactive control treatment for women with incontinence. The method we used was the Cochrane Methodology for systematic review and the GRADE approach. In total, we had 21 trials involving 1,281 women that contributed to the review, and 1,051 women with this, we had 7 new trials. So among the 21, we had 7 new trials. There was variation in the intervention, population, and outcome, and there was no trial of women with urge alone or mixed incontinence alone. They were either stress alone or all type of incontinence. And then we looked at the trial in terms of risk of bias. And at the bottom, you can see the risk of bias table for all the trials that were included. And green would be low risk of bias, yellow, moderate risk, and red, high risk. So as you can see, it's quite good. The trials are mostly moderate or low risk. These are the results. Women with stress incontinence had high quality evidence that, that's from 4 trials that women with stress incontinence in pelvic floor muscle group were about 8 times more likely to report cure. Women with any type of incontinence, there was moderate quality of evidence from 3 trials that women with all UI type in pelvic floor muscle group were 5 times more likely to have incontinence. And the results were similar for cure and improvement. So let's go to the secondary results. Women were more satisfied with active treatment in the control group and were more likely to not seek further treatment in the treatment group. Women treated with pelvic floor muscle training leaked urine often less, lost smaller amount, and emptied their bladder less often during the day. Their sexual outcome was also better, and the persistence of benefit in medium and long term was supported by 2 small studies. So long-term effect was not so studied. There was often no adverse effect reported, and when they were small. So the conclusion was that moderate to high level of evidence exists that pelvic floor is better than no treatment. So we know that pelvic floor is efficient for stress incontinence or urinary incontinence all type. But as I showed you, there is not specific study in other different types of incontinence. So the evidence is for all type or stress. We added 7 trials and didn't change the main finding of the review. There was a lot of secondary outcome, a wide range, so the quality of the evidence is improved by that. However, there was no cost-effective trials, and long-term evidence was only supported, as I said before, by 2 trials. So what do you have? We have effectiveness in stress or in all type. We don't have so many studies in mixed incontinence, which is very important for us in older women. We don't have cost-effectiveness trial, and we don't have long-term follow-up, which means that the next studies we're going to be doing, we need to look into cost-effectiveness, and we need to look at long-term follow-up. Okay, so that leads us to the second part, and tomorrow, if you come back, I will be presenting to you the better treat. What are the trials we develop with the dancing, and you're going to dance. We're going to start talking also about prediction. It was longer today to talk about the better understand because, as you can see, first we had to do that before doing the rest. So we are not so much advanced in the other component of our research chair. So I'm going to have enough time tomorrow to present you the rest of the story. But today I wanted to put the table to show you what we had to do first, the better understand. And now that we better understand, we can move on to the other objectives. Thank you.
E o pessoal que está assistindo na TV USP, são mais ou menos 150 pessoas que estão assistindo. Também podem fazer pergunta ou via e-mail, ou quem tiver o meu contato. Alguém? Tantos especialistas na plateia? Algum comentário? Alguma pergunta? Yeah. Acho que tem que tentar falar. Pergunta aqui.
Sorry. I saw your study about the cognitive function of these patients, and I'm in doubt if the tests that you in your team do, the physical therapists could applicate, or only the psychologists?
Yeah. In that study, it was a collaboration with the neuropsychology professor, and the tests were all done by the neuropsychologists. Yeah. Not by the physiotherapist. We wanted to make sure that it was well given, you know, that it was well standardized. Yeah.
Thank you.
Pessoal, só antes de todo mundo ir embora, todo mundo assinou essa lista? A gente vai enviar o certificado para vocês por e-mail, tá bom? Depois de amanhã.
She wants to ask if you have ever done any research comparing people who have experience with dancing, or other, comparing those that had experience in dancing with those that don't have, if they have any difference in the organocological functions.
Okay. I didn't show you anything yet about the dancing. Tomorrow I will talk about the dancing. The idea, why I just introduced it today is just to make the link with the lower limb problem, cognition problem, and the dancing. And actually there's a research team in Switzerland with Dr. De Broom who's using dancing for patients who are fallers. So the use of dancing compared to the use of just walking in the parallel bars and doing regular exercise. So he did compare that and found that the patient was much more adherent to the dancing and the improvement was much faster. For us, I will present to you tomorrow what was the impact of the dancing compared to the regular exercise. What was the also impression of the women? Because we did a small focus group after the dancing. But that's for tomorrow. Yeah. But there are other places in the literature with the elderly where they use video games and dancing for this kind of problem. We were the first thing who used this, I think, for the elderly and incontinence.
A question from the internet. It's from the Simone Botelho group again. She's asking if you stratify the age for your elderly patients, if you take into account that, or if you stratify in your studies the age.
Yeah. Which is she talking about, the lower limb or the cognition? But anyway, all of them, when we have comparing two groups of patients, continent and incontinent, we always try to match them, or we make sure that the age, effectively, the age would have an impact on the pelvic floor, on lower limb function, and also on cognition. So yes, we do that. Yeah. Either we match, either we use statistical method to account for that. So we use ANCOVA, for example. Yeah, so depending on the study, we do different things, and she can find that in the publication.
Do you compare the groups, for example, till 60s or from 60 up to 70 or something like that? Do you compare these groups?
Depending on the trials, if it's a large trial like the cognition study in which we had 89 subjects in the incontinent group, and because of that we had a wider group, we did some comparison. Remember, the people who are participating to our studies are very fit, you know, to come to the research center and to be interested in the study. So they are physically fit and mentally fit. So even if there is an age gap, the difference is not as big. But yes, we do look at that. Most of the patient are an average of 70 years old. 5 years before, 5 years after. So we don't have the 100 coming to our lab.
You showed us different exercises for different types of incontinence. You said that the neck, for example, is very good for the stress urinary incontinence.
Yeah.
And could you give? I thought it was a very great research, and I was curious about the type of exercises you used in the different groups.
In that study that I showed you, we just looked at what we found in the first study with the dynamometer. You know, problem with the tone, problem with the rapidity. So we did the exercise in the same way we did the test. And we repeated that. So for example, the 10 rapid contraction, the rapid contraction in 15 seconds, that was a test. And because they had difficulty in that, we used that as an exercise after. So they had to do as many rapid contraction in 15 seconds. In
the same positions?
No. You're too curious about tomorrow. I'm going to talk about the program. But yeah, what we decided was to work in different positions, from lying to sitting to standing, and at the end with open legs in different positions. But yes, we, in that first research, we had exercise that were low intensity but maintain a long time, which is something that has been thought to be related to increased tone. We had also exercise with rapidity. We had also exercise for coordination. We also had the neck. So we tried to mimic in our exercise what was found in the dysfunction of the muscle, as much as we could. And we did pilot to see if that was changing. So with time, with all those studies, we built a final exercise program, which I'm going to be presenting in all the details tomorrow. Yeah.
I know. The presentation was wonderful.
Oh, thank you.
I'm curious about the study of a jury. I think that it's an interesting approach.
The jury.
Yes.
It was really fun. It was really fun.
Interesting to approximate the population to the researchers, and they can discuss together.
In University of Montreal, and also I think in Canada these days, maybe in Brazil too, they think that the patient is the partner. They want to involve the patient more and more into the research. So this was something that I saw that it was done in the UK. They have the James Lynn Foundation, and they do that for different things, not only for incontinence, for other problems. What are your needs? They ask the patient first. And because they know more about the needs of the patient, they may be able to find intervention that suits more the patient. I think about diabetes patient, that you're studying. I'm pretty sure, there probably are some things that they see that we don't see and they probably contribute a lot of giving you insights.
Yeah, it's exactly this. I was thinking about to do this with the diabetic ones, but I saw that your patients, it's with a high level of education.
That's a limit. That's what I said. That's a limit. And what we wanted to do with the jury is we communicate with the foundation. We also put some ads in the paper, and the people who came to us were those people. So we are saying this is a limitation because it might not represent all the women that have incontinence. But on another note, somebody was telling me, but maybe these women are the ones that will come for treatment also.
Yeah.
So it's difficult. Of course, it would be interesting. Now that we have the new International Consultation on Incontinence chapter, we were thinking maybe about doing another citizen jury, but this time, because it's a lot of organization with all the presenters in the morning, so we were thinking that maybe having something filmed and having it in different cities in Canada with the foundation association, that could be another way, and maybe with higher groups, we would be able to get maybe more of the different population. But yeah, it's a limitation. I agree with you.
Yeah, and I think about the internet access. These people normally they can access internet with easier.
Exactly.
And the low education ones, maybe not.
Low education, low income, maybe not. You're right.
Thank you.
There's a question over there.
I think this one is a good strategy of adherence. But which strategies you use for the adherence of pelvic floor muscle training, or in the outcome and the outcomes and the
tomorrow when we talk? Tomorrow I'm going to be talking about adherence strategies. Just a peek about tomorrow. We did at ICS in the past years a State of the Science seminar. We invited 17 experts that had worked on adherence to exercise. Some of them were psychologists, some of them were doctors, physiotherapists, nurses, and at the end, this is what you need for adherence. We did 5 papers, a large literature review, and the main paper is a consensus statement on how to improve pelvic floor muscle training. And tomorrow, the next slide I will not show you because these are the actual tips for adherence. But there are in the literature some strategies, some theories on how to improve adherence. A patient might be at one level, he's not ready to comply. So maybe you can do different things to help that patient change his behavior, at least adhere to that, and then change the behavior. So if we are using more these theories, we can have an impact. So tomorrow I'll give you concrete tips about that.
Okay, thank you.
Thank you.
Então a gente encerra. Então, a gente encerra o curso hoje. Obrigada pela presença de novo. Vocês é que fazem esse evento acontecer. Amanhã a gente começa de novo às 9 horas. E está previsto até às 10h30. E aí é o último dia desse curso de pós-graduação. Convidamos de novo vocês para sexta-feira à tarde, lá no departamento. Ou quem quiser assistir pelo IPTV, é o mesmo link de sempre. Para aqueles que estão ouvindo a gente, ou para aqueles que vão ouvir ela pela TV USP, não usem o browser Chrome, porque eles estão desabilitando uma porção de recursos, como Flash, atualização de Flash, que precisa para assistir o vídeo. Então, ou usa o Firefox, ou usa o Safari, ou algum outro, ou o Internet Explorer, mas não o Chrome. Tá bom? Obrigada a todos novamente.